Hello, everybody. Welcome to our webinar today, the 2021 Canadian Antimicrobial Resistance Surveillance System Report, Key Findings and Remaining Gaps, presented by the Public Health Agency of Canada. My name is Margaret Howarth-Brockman. I am the Senior Program Manager at the National Collaborating Centre for Infectious Diseases, and I'm happy to be today's host. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy. I'd like to start by acknowledging that NCCID is located at the University of Manitoba on Treaty 1 original lands of the Anishinaabe, Cree, Oji-Cree, Dakota and Dene peoples, and on the homeland of the Métis Nation. We recognize and speak the truth about the historical and present damage of colonization, and we strive to work towards reconciliation. Today's webinar is also co-hosted by the National Collaborating Centre for Methods and Tools, and I would like to invite Emily Clark from that Collaborating Centre to say just a few words.
Wonderful. Thank you, Margaret. So I'm Emily Clark. I'm a knowledge broker at the NCCMT for Methods and Tools. Hosted at McMaster University in Hamilton, Ontario, on the traditional territories of the Mississauga and Haudenosaunee nations. The NCCMT supports health professionals and organizations integrate evidence-informed decision-making with online resources, training, as well as workshops, virtual and in person. I'm very pleased to be part of this webinar today. Thank you for the invitation, and I look forward to hearing more from our speakers.
Thank you, Emily. So there are a few housekeeping items I would just like to mention before we go forward. We are offering closed caption transcription of this webinar as it goes forward. We are also offering simultaneous interpretation. So if you prefer, you may wish to switch to the French channel to hear the presentations and the discussion. Today's event will be a moderated discussion after the presentations, and we are clearly running this webinar through Zoom. If you have any technical troubles with Zoom, please email us at nccid@umanitoba.ca. Thank you to those of you who shared questions for the panelists ahead of time. You can also use the question and answer function during this session to submit additional questions for the panelists. And while we may not get to all of your questions in today's session, they will be used to help inform future events developed by NCCID and the agency. The chat is disabled for participants, but the speakers and hosts will use the chat tab to share additional information with you. You will see already that we have let you know that the recording of this webinar and the attendance slides will be available shortly afterwards at www.nccid.ca. So I'd like to now introduce Dr. Dawn Shepherd. Dr. Shepherd is the Executive Scientific Director at the Antimicrobial Resistance Task Force of the Public Health Agency of Canada and practices clinical infectious diseases and medical microbiology at the McGill University Health Centre. Dr. Shepherd's research interests focus on elucidating the mechanisms by which biofilm-forming microorganisms cause human disease and resist antimicrobial therapy in order to develop new therapeutics for these infections. And Dawn is going to say a few words before introducing today's speaker. Thanks, Dawn.
Thank you so much, Margaret, and well done on the biofilm forming organisms. That's not exactly on point for today's meeting, but it is a major way that microbes are resistant to antimicrobials. So first of all, let me acknowledge that I am joining you from the traditional and unceded territory of the Anishinaabe Nation to add to the list of land acknowledgements. So Margaret, you mentioned the AMR task force, the Antimicrobial Resistance Task Force in the Public Health Agency of Canada. And this was a group that was stood up in October of 2021 in order to centralize functions in AMR and AMU, antimicrobial resistance and antimicrobial use, and to drive forward progress on policies, programs, actions, and coordinate the activities across the various federal departments that have an interest in this area. So we have the CARS report under our purview, hence the reason we are joined here today. But the CARS report, of course, does not come together without the key contributions and the close work that we must do with the Center for Communicable Diseases and Infection Control, the Center for Foodborne Environmental Zoonotic Infectious Diseases, who has the best abbreviation anywhere, CEPHESID, such a great abbreviation, and the Center for Immunization and Respiratory Infectious Diseases, not to mention, of course, the National Microbiology Laboratory, all portions and pieces of the Public Health Agency of Canada, who collect, analyze, put together, and are generally responsible for the data that then appears in the report we're discussing today. I also want to put a few thank yous in, most notably to the NCCID, to Margaret and her colleague Harpa Isfield-Keeley, who together with the rest of the NCCID have been involved in the AMR dossier for a very, very long time, probably longer than I've worked on AMR, who've helped to mobilize knowledge into action for many years, and we greatly appreciate their commitment and their help with today's event. It was mentioned that the NCC on Methods and Tools is joining us today. Welcome to the AMR space. We welcome your expertise in supporting the development of evidence-informed decision-making in healthcare. We think that's going to be particularly helpful in surveillance and stewardship, and look forward to your contributions. So now that the thank yous are done and the explanation of the task force, we're ready to head into the main event. Today, you're going to hear from me, obviously, and from my colleagues from the task force, Jason Shergold, who's the acting manager in surveillance, and one of our senior epidemiologists, Oscar Niragira, who's performed many of the analyses that you're going to see today in the presentation of the report. They are primary authors on the report, and without further ado, I'm going to let them share the important information contained within the report. Jason, over to you, I believe.
Hi, Don. You can hear me okay?
Perfectly.
That's great. Well, good morning to everyone from sunny but cold Ottawa, Ontario, and thank you for joining us for today's webinar. And thank you to the NCC group for hosting us. Some housekeeping notes before I start. I'd like to remind everyone that this webinar is being simultaneously translated in French, and that the presenters may leave an occasional pause to help those joining us on the alternate channel. We're also pleased to offer this content visually in both official languages, although I'd like to apologize for the occasional wall of text that this creates. Without presuming the background of everyone joining us, antimicrobial resistance, referred to as AMR, is a growing concern that threatens the continued success of nearly every aspect of modern medicine. AMR occurs when microorganisms change in ways that help them survive exposure to antimicrobials, which makes it more difficult to treat some types of infections. AMR is recognized worldwide as a major threat to global health and is already having a major impact here in Canada. The Council of Canadian Academies estimated that in 2019, AMR was responsible for 15 deaths every day, and that the financial impact to the healthcare system can already be measured in billions of dollars. With this in mind, my colleagues and I would like to present some of the more recent findings of FACT's national surveillance data to help contribute to the growing mosaic of evidence that AMR is escalating here in Canada. Before we move to the results, we should understand how we're drawing our conclusions. And while Oscar and Don get to facilitate the discussion on the fun parts, I drew the short straw and have the privilege to walk everyone through some of our methodology. This is important, though, to give everyone the chance to understand what this information represents and to give everyone the background necessary to recognize where some of our gaps remain and how we plan to improve. First, not all organisms are created equal. To help focus national surveillance efforts for AMR, Canada has developed a list of priority organisms listed here. While FACT conducts surveillance on some emerging AMR organisms, such as a fungal pathogen called Candida auris, we've chosen a subset of results to present to you today. The data presented in the 2021 CARS report is a result of an extensive network of collaborators. While the Canadian Antimicrobial Resistance Surveillance System, known as CARS, has moved to fill some gaps in national surveillance, the majority of information is generated by our partner programs, all of which contribute to the CARS banner. We are thankful to all those involved, both internal and external to FACT, while recognizing that much of this work was completed in parallel to the COVID-19 public health response. In most cases, the AMR surveillance programs here at FAC do not collect information on all infections for all priority organisms. National surveillance at FAC regularly relies on sentinel surveillance, which is a method that generates high-quality data that can detect epidemiological changes over time, but this method does not necessarily count every instance of AMR that occurs in Canada. For example, the FAC Sentinel Surveillance Network that generates AMR data in hospitals, known as CNIS, consists of 89 participating facilities with representation from all provinces and 1 territory. These hospitals are capable of detecting AMR infections in hospital inpatients and work to determine if the infection was attributed to the healthcare system or if the infection originated from the community sector. The rates produced by this level of evidence help to inform where the burden of AMR is originating and where targeted interventions would be most effective. Alternatively, we source other data from federal, provincial, and territorial partnerships, where data are shared between public health labs. For this methodology, FAC surveillance is much closer to detecting nearly every diagnosis. However, for some of these systems, very little is known about the patients themselves. In addition to the hospital and community sectors, people can be exposed to AMR through food. To help monitor this, FAC, through the CPARS program, conducts a multi-pronged approach to test for AMR at various stages along the food chain, including the testing of retail meat being sold in 4 provinces, abattoir facilities, and on-farm animals. Up until this point, we focused primarily on AMR. However, we've learned that there's a strong relationship between the emergence of AMR and how we use antimicrobials, which we call AMU. In brief, the more antimicrobials are used, the faster AMR becomes a larger problem. As a result, FAC conducts national surveillance that estimates the total number of antimicrobials dispensed through retail pharmacies, as well as the total quantity of antimicrobials purchased by Canadian hospitals. These data are primarily sourced from a company called IQVIA, who work with the pharmaceutical industry in multiple countries to acquire their data. Likewise, antimicrobials used in animals and food production appear to contribute to this AMR-AMU relationship as well. FAC conducts surveillance on AMU in animals through a variety of channels, including data reported to FAC and Health Canada on the sales of antimicrobials intended for use in animal populations. The CPARS group also uses a sentinel network of farms to generate additional evidence on how and why these antimicrobials are actually used. I hope this first section helped to bring some clarity on the ways that we collect our information on AMR and AMU. Before I hand the presentation over to Oscar, I want to point out that the report itself will have links to the full methodology and much greater detailed number of results. For example, you can find heat maps that visualize the specific bug-drug combinations for each organism, which may be more suitable for some of the medical microbiologists joining us today, as well as better understand some of the nuances of the contributing sentinel systems. Okay, Oscar, over to you.
Thank you, Jason. As Jason mentioned, this is the time for the key findings. They are drawn from the main report on the 2021 CARS report, which is Canadian Antimicrobial Resistance Surveillance System report. These are the main findings drawn from the main report. Next slide, please. This is the slide about MRSA, methicillin-resistant Staphylococcus aureus, showing trends between 2015 and 2019. MRSA is an organism that is resistant to commonly used antimicrobials and is historically associated with the healthcare sector. However, an increasing number of hospitals are admitting patients with the MRSA bloodstream infections that are attributed to the community. While MRSA bloodstream infections associated with the healthcare sector are relatively stable, from this figure, it's clear that MRSA BSI associated with the community sector have more than doubled since 2015. To help better understand these findings, CINCIP is working to help identify the source of these infections and investigate any association to injection drug use and opioid crisis. Next slide, please. This is a figure on healthcare-associated carbapenems producing antibacterials. CPEs are organisms that are resistant to carbapenem antibiotics, a class of antibiotics that are important to treat MDR infections, multi-drug-resistant infections. The number of inpatients identified as harboring these organisms rapidly increased between 2015 and 2019, followed by an increase in infections starting in 2019. CPE is becoming increasingly detected, likely due to, in part, the increase in screening practices by sentinel hospitals. However, while only 110 infections were detected by the sentinel network in the past 5 years, the corresponding rate in 2019 was double the rate observed in 2017. We are unsure of the reasons behind the slight decrease in colonizations in 2019, but the increased identification of CPE infections represent a growing threat to the continued effectiveness of carbapenems. The infections contribute to the healthcare system more than doubled, but we can see that the crude mortality has increased also, and it was 21% in this period. Next slide, please. This is a slide showing Coccidioides difficile infection between 2015 and 2019. The rate was calculated per 10,000 patient days, and the CDI are known to occur following the use of antimicrobials or hospitalization. From this figure, we can see that infections attributed to healthcare system decreased by 22%. Infections attributed to the community decreased by 22% also. And the overall crude mortality was 9%. Attributable mortality was 2%. The rate of CDI has consistently decreased since 2015. However, recent preliminary data from 2020 are not shown. But they suggest that rates could be increasing again. The Public Health Agency of Canada, PHAC, is currently investigating the relationship between COVID-19 and the hospital sector antimicrobial use, which may provide some clues into this apparent increase. Next slide, please. This is a slide showing MDR gonorrhea trends between 2015 and 2019. Gonorrhea is the second most common sexually transmitted disease in Canada and is becoming increasingly resistant to first-line antibiotics. The rate of gonorrhea infection increased by 70%. The proportion of cultured multi-drug resistant isolates increased from almost 90% to almost 12%. And the incidence of gonorrhea infection has rapidly increased in Canada, with over 1,040,100 cases reported between 2015 and 2019. Current antimicrobial susceptibility testing for AMR covers approximately 20% of this diagnosis, which has detected an increasing trend in the proportion of isolates classified as multi-drug resistant. Of particular concern, Canada has identified 11 cases of extensively drug-resistant gonorrhea between 2015 and 2019. While still under investigation, the most recent case known to be cephalosporin resistant was reported in late 2021 and is the first case in Canada to not have direct associations with international travel. Next slide, please. This is a slide showing the antimicrobial use in humans between 2015 and 2019. Prescriptions were per 1,000 inhabitants, and data are stratified by age groups. Antimicrobial use in humans decreased by 5% overall, but there are some areas of concern. Per capita AMU in seniors aged 80 years or more increased by 24% between 2015 and 2019. The use of carbapenems in the community increased by 68%. And it's clear the overall decrease between 2015 and 2019 is clearly shown in this figure, but AMR remains the highest among Canadians aged 65 years or more. The one-year trend from 2018 to 2019 looks encouraging for all age categories, especially as these years were unaffected by COVID-19. Of particular concern, however, is an increase of 68% of the community use of carbapenems. The reasons for their use in the community is currently being investigated. Next slide, please. This is a slide showing antimicrobial prescribing in the community sector before and during the COVID-19 pandemic. The start of the Canadian pandemic period was defined as March 2020, corresponding with the closure of the Canada-United States land border. Between March and October 2020, the overall rate of antimicrobial prescribing decreased by 27% when compared to the same 8-month period in 2019. The rate of prescribing in the community setting, visually here, was heavily impacted by the COVID-19 pandemic, and with the rates of prescriptions decreasing by 27% for the first 8 months of the pandemic. These findings are similar to results published by international partners. However, we are closely following recent evidence that in hospital antimicrobial use increased dramatically, and the rates of AMR and COVID-19 positive patients are also increased during this period. PHAC is currently working with its partners to determine if these hospital trends hold true in Canada. Next slide, please. This is a slide showing antimicrobials intended for use in animals between 2015 and 2019. Antimicrobial use in animals appears to be trending down, but should be interpreted with caution given updates to regulations enacted in 2018. Antimicrobial sales for use in pigs, poultry, aquaculture decreased between 2018 and 2019, and antimicrobial sales for use in cattle, horses, companion animals, and small ruminants also increased. The sales of antimicrobials intended for use in animals appears to be trending down overall, but our method for monitoring these trends changed at the end of the year 2017. As a result, findings should be interpreted with caution. Note that these findings are presented using a metric that adjusts for weight and population of the animal, known as a PCU, Population Correction Unit. The full technical description is included in the full report. If you are interested in learning more about these trends, the CPARS, the Canadian Integration Program of Antimicrobial Resistance System program, have released data up to the year 2020. Please contact us if we have trouble finding their publications. Next slide, please. Antimicrobial sold for use in animals were also analyzed using the international view. So this is international perspective comparing the antimicrobial sold for use in animals across different countries in Europe. In total, we have 31 ISVAC network countries. This is the European Surveillance of Veterinary Antimicrobial Consumption Network, which collects and reports data on the quantity of antimicrobials intended for use in animals in 31 European countries. Canada ranked 8th highest. Through collaboration with the European Surveillance of Veterinary Antimicrobial Consumption, PHAC is able to compare sales of antimicrobials intended for use in animals to those reported by 31 European countries. While Canada, represented by the horizontal red line on this figure, ranked 8th highest in 2019, there are some excellent collaborations currently taking place that are attempting to improve the use of antimicrobial consumption standards in some animal species through initiatives such as national AMU targets. Next slide, please. This is a slide showing the integrating information on antimicrobials using the quantities of antimicrobials intended for use in people and animals in 2019 and certified by antimicrobial class. Many antimicrobials that are very important for human health are not widely used in animals. Example, carbapenems, the broadest spectrum antibiotic, are not used in animals. Finally, while the majority of antimicrobials in Canada were consumed by animals, we have to recognize that there are a lot more animals than people. As shown on this figure, we can see that adjusted for populations and weight, animals actually only use approximately 1.3 times more antimicrobials. This use, however, is not equally distributed across all antimicrobial types. For example, the use of tetracyclines heavily favors consumption by animals, whereas as the use of other antimicrobials, especially those of very high importance for human medicine, such as carbapenems, are not used in animals at all. Thank you for listening. I hand over back to Jason.
Actually, I think it's over to me. So thank you very much for that, Oscar. So you can see that grosso modo, looking at all of this data from a very high vantage point, there's some encouraging news on antimicrobial use. However, antimicrobial resistance trends continue to be concerning in most, if not all, of the major pathogens. Clostridium difficile, of course, being more an indicator of antimicrobial use than a resistance problem per se. So that's the data, but we wanted to take a step back and look at actually how our systems are working. And I want to revisit some of the points that Jason mentioned earlier. So as part of my task when we established the task force, I've done kind of a virtual cross-country tour speaking to people in the area of antimicrobial resistance. We've also had several assessments of the Canadian surveillance systems recently that have been performed, one in collaboration with the NCCID. And so taking all of this together with some of our own analysis, we've looked at what we're currently doing now, what perhaps in an ideal world, if all was wonderful, we had infinite funds and infinite resources we could be doing, and map the two together to identify where some potential gaps are in the surveillance that we're doing now. So if you could go to the next slide for me, Jason. This is our simplified version 1.0 of potential gaps that existed at the time of the start of this analysis, which was in 2021. So the first gap is already been alluded to by Jason. We rely heavily on some excellent sentinel surveillance systems in this country, and they provide us with very good high quality data. But what we don't have, of course, is comprehensive data. We don't have data on every infection in the country. And there's always the question of how do our sentinel systems map to the healthcare network? Are the hospitals in our CNIS program representative of all hospitals in Canada, or are they polarized, for example, to tertiary care centers? And we need to look at community hospitals, rural hospitals, long-term care centers. And then there's the data we collect itself. When we looked at the MRSA trends, we can tell you that there is an increase in MRSA infections, but we can't necessarily tell you whether that's because there's an increase overall in bloodstream infections, including MSSA, sensitive infections, and resistant infections, or if the rate of resistance has gone up because we don't have the same reliable data for the sensitive infections. So there's the two aspects that limit somewhat our ability to report up our data to international partners. The second point I've highlighted here, the integration of data sets, is to highlight that, this data is out there on hospital lab information systems, on electronic medical records, in provincial and academic databases. And there are many initiatives collecting data that we could actually be using and incorporating into our national surveillance. For example, looking at the appropriateness of the antimicrobials that we've just reported on. We can tell you now how many antimicrobials are being used, but not if they're being used appropriately. Things like the National Antimicrobial Prescribing Survey that is being done can provide us with some valuable information on how reliable or how appropriate these antimicrobial prescriptions are, at least on the human side. We take a One Health approach to antimicrobial resistance because, as the CPARS program has illustrated, antimicrobial organisms can be bred in animal populations and move to humans and vice versa. But there's also the environment to consider, and we have very little surveillance, in fact, as most countries do, in the environment, and whether that's looking for antimicrobial resistant organisms or antimicrobials themselves, we do very little of that worldwide, quite frankly. Akin to that is the genomic tools, which can be helpful in monitoring antimicrobial resistance in places like the environment, but are also very helpful at tracking organisms and sort of elucidating the smoking gun of transmission and moving past simply identifying resistant organisms in one place and in another place, but actually linking those two and saying, hey, these are the same bugs that have moved through a matrix from point A to point B, and linking paths of transmission. Lastly, and not least, obviously you will have noticed we are in 2022, presenting a CARS report from 2021 with data that largely ends in 2019. And that's an artifact of the way these systems were built, the effort that's put into collecting high quality data in a Sentinel system, but that puts a delay in the data that makes, of course, it more challenging to use it the way people would like to. So that's where things were when we first looked at the system in 2021. Next slide. But we never like to present bad news without some good news. So I want to highlight the fact that in budget 2021, there was a significant investment in surveillance systems in this country. 28.4 million over 5 years with 5.7 million ongoing that was earmarked for a number of initiatives in AMR, but a large portion of which was to surveillance and monitoring in order to control and prevent AMR. And so I'm going to turn it over to Jason on the next slide, and he's going to tell us what some of those initiatives are and how they map to those gaps that I told you about. Over to you, Jason.
Thanks, Don. We are very excited about a number of changes here at FAC that aim to improve our response to AMR. Allow me to take a moment to introduce some of these new activities listed here. First, we spoke earlier about using laboratory data to better capture the number of AMR diagnoses picked up by national surveillance. The AMRNet program is expanding to work with additional provinces and territories to build a national database designed to capture many pieces of information, including results that show how susceptible or resistant the isolates being tested are to specific antimicrobials. In many cases, this information is already routinely generated by our partners in public health and used by healthcare practitioners to prescribe the right antibiotic. Bringing these sources of data together would greatly accelerate our ability to establish national estimates for AMR in Canada. We also spoke earlier about the CNIS program, which uses a Sentinel network to detect changes in the epidemiology of AMR infections in hospital inpatients. FAC is working to identify specific areas in Canada in which CNIS representation is limited so that we can recruit additional hospitals and make improvements. We're also forming the basis of a national AMR surveillance in long-term care facilities to help us understand more broadly the impact of AMR on seniors. Third, FAC is committed to improving surveillance in the community sector. As we've learned earlier, AMR gonorrhea is becoming a big problem here in Canada. Funding from Budget 2021 is helping to expand the surveillance program specific to gonorrhea, known as ESAG, to help us better understand where these high-risk infections are occurring and what can be done to prevent them. Additionally, as only about 20% of gonorrhea diagnoses are tested for AMR in Canada, FAC is looking at new lab methods to predict the presence of AMR in a higher proportion of diagnoses. FAC is also partnering with a group that specializes in the analysis of data sourced from primary care physicians through the use of electronic medical records. While these records can never be used to identify a single person, the data can be used to see how many AMR infections are being diagnosed in primary care and, in time, can be used to help track inappropriate antimicrobial prescribing practices, a factor that is closely tied to the acceleration of AMR. FAC is also committed to expanding AMR surveillance to more segments of the food chain, including the collection of AMR and AMU data from beef and dairy cattle, and expanding the reach of retail food testing for AMR. Finally, moving a little closer to One Health coverage, FAC is well positioned to take advantage of recent developments in the testing of wastewater for SARS-CoV-2, which is the virus that causes COVID-19. We are starting the process to monitor wastewater for the quantity of antibiotics, which will help to form the basis of knowledge on how antimicrobial consumption could be impacting the environment. Now, in addition to these, let me pass this back to Dawn to talk about some of the other near-term opportunities that we have moving forward.
Thanks, Jason. Why don't we click on to the next slide? So those were the investments specific to the budget 2021 that Jason highlighted. But of course, there are many other areas where FAC and its partners are working to try and close some of those gaps and improve the quality of surveillance data. In terms of integrating existing data sets and programs, what I highlighted before, AMRNet is a big step forward, but there are many other databases, academic programs, and provincial programs out there that we would like to bring together into a mosaic of surveillance data. This is how most countries, including the European nations, put their surveillance data together. And instead of letting perfection be the enemy of good, it's taking whatever data we have and presenting it with all of its limitations in a way that makes it accessible to individuals. And I've listed some of the programs that we've had conversations with here in the bullets so that you can see the direction we're going in. From One Health coverage, Jason mentioned wastewater surveillance for AMU, antimicrobials, but of course, we use genomic methods to look for SARS-CoV-2 in wastewater. And we'd like to build on those techniques and technologies to develop testing protocols to measure AMR. Of course, AMR is much more complicated than SARS-CoV-2. We have many different targets, but there's an initiative funded through the federal government, the Genomic Research and Development Initiative. It's called AMR 2.0, which is looking at developing genomic tools for environmental matrices like wastewater. This same initiative is also supporting tool development for other aspects of AMR surveillance, in particular things like looking at genotype-phenotype relationships, using genomic information to predict antimicrobial resistance in phenotypes. So in cases like gonorrhea testing, where we are making diagnoses based on nucleic acid testing and not culture, having backup systems that can actually predict whether that's a resistant isolate or not without the isolate ever having been cultured, and improving the flow through of some of our resistance testing by moving past phenotype testing. And then lastly, the timeliness of reporting. We're working on moving past a single annual report that comes out in a PDF 9 months into the year and trying to make data more accessible in real time with dashboards and interactive visualizations on our various web pages. And I believe if we go to the next slide, Jason can give us an example of how we're looking at antimicrobial consumption as a dashboard that you can actually go to now in real time.
Sure, maybe I'll go against conventional wisdom and see if I can pull it up live.
You're a brave man.
So this was recently launched through a collaboration between my program and Infobase to help improve the timeliness of the data behind some of our national antibiotic consumption statistics in humans. And the idea being that if we can remove some of the lag that's associated with publications, you should be able to come down to a heat map and actually interact with the data a little bit more carefully to find the trends that are most important to you. This is a bilingual tool accessible in both official languages, and you also have access to the raw data as it changes as you interact with the figure. I can say that there's a number of AMR programs, a number of our surveillance partner programs that are also developing tools. And so contact us if you'd like to be put in touch with the people who are developing these. But I'm limited by what I can say because a lot of the programs, they want their own big announcements, but this is moving a little bit closer to the future of open data accessibility here at the agency.
Thanks, Jason. Can you flip us to the, I believe is our conclusion slide? Yes. So to wrap all of this up before we move into questions, I think hopefully you've heard the message loud and clear that we have strong sentinel surveillance programs that provide us with Canadian AMR and AMU data. There are, of course, some gaps that remain. We recognize some of the limitations of this data, particularly when it comes to integrating other data sources and generating national level statistics with the granularity that we would perhaps like. But we're working hard to close those gaps, both with the recent investments from Budget 2021 and other sources and other creative ways to actually look at bringing in data and sharing it as promptly and effectively as possible. So of course, that does lead me to, before the questions, just an invitation, an open invitation. We only can seek to incorporate data that we know about. So if you are aware of programs, surveillance systems, databases, or other interesting ways that we can bring in data and work in collaboration to share this data with Canadians, please reach out to us. That was the reason for the Cross Canada tour, and the tour isn't over. So by all means, drop anyone, including me, an email, and we'll be happy to chat with you. So with that, we're going to move into the question period, but to warm you up for the questions, I think we have a poll. And if I'm not mistaken, we can pop up that poll. And the poll is a question from us to you. You heard from us what the gaps were that we had identified and that we had heard in our consultations. So we'd like to hear from the few hundred people here today. Out of these gaps that we discussed, which would you prioritize? If someone put you in charge of surveillance systems, how would you order this list and which one would you focus your efforts on? And the winner is integration of existing data sets and programs. Well, that is very heartwarming to hear, given how much energy we're putting into it and the fact that it was the closing line from our presentation. So with that, I think I will pass it over to Margaret, who's going to orchestrate the Q&A. If I could ask Oscar and Jason, you're already there, to join me in person with our cameras on, our pencils sharpened and our ears wide open. We are ready to take your questions.
Well,
oh, sorry, Margaret, if I could derail this, I'm just interested to know, Dawn, are you surprised by those results?
I think what it informs me, Jason, is that I did a decent job on that cross-country round tour, or that all the people I spoke to are the people in the audience, because that was a message I heard loud and clear in talking to people. So it's very reassuring to know that my Sentinel surveillance system of asking people was representative of the larger Canadian opinions, assuming that our audience represents the larger Canadian population.
Well, super. I mean, it's a great way to start us off for this next portion of today's webinar. Thank you for turning on your cameras. I'd like to remind our attendees that you are very welcome to post your questions in through the Q&A tab, which is there on your screen, the Zoom link. And I want to thank you for presenting and informing us of the new developments. I actually think this is the first time that the CARS report has been presented in this way to a large audience across Canada, including the information about new developments and where you think the way forward will be. So we do have a number of questions that have come in, but I'm going to start off with one that came in earlier before the webinar. So you spoke a bit about the decline in antibiotic use in hospitals at the beginning of the COVID-19 pandemic, but at the same time, we know that many people were getting primary care via virtual meetings with their physicians or nurses. So are you able to comment at all on the changes in antibiotic prescribing due to or coinciding with virtual care?
I can start that off if you like at a higher level. So there's been quite a bit of analysis internationally and nationally, particularly with some of the provincial data, looking at what exactly happened with community AMU, because that's, of course, where we saw the shift to virtual care. Interestingly, when you dig down into the data, the suggestions are that when people needed antibiotics, they got them. There wasn't a huge change in prescription rates for example, skin and soft tissue infections or community UTIs, but they were huge drops for upper respiratory tract infections, the place where we see this massive, probably inappropriate use of antibiotics. And of course, there's two things that make that up. One is the virtual care and making it more difficult and people not bothering when they didn't actually get to see a physician and the physician holding off on the prescriptions. But of course, the second part was that the rate of upper respiratory tract viral infections plummeted in 2020 as a consequence of the public health measures. Many of us lived from March to December of 2020 without a cold for the longest time in our lives. And so that also had a major impact. And what we really need to do is look into 2021 data once things have settled down with the sort of residual virtual care that is still going on, sort of the balance between where we were when it was all virtual to where we are now, where it's a hybrid system, and see how much of that is durable. There's already been some signals that it's creeping back up to where it was before, but whether that's because of an increase in viral infections or a better version of people using antimicrobials appropriately, now that the community understands the difference between viral and bacterial infections in a way they never have before, we need more data to say.
Thanks, Don. And I think this sort of ties in with the first question that was posted, which is in the graph that you showed, Oscar, with your results, you had the influence of COVID pre-2019, obviously pre-COVID, and 2020. So I think there just needs to be some clarification on that slide and what the trend was that you were depicting there. Is that something we can pull up? I think it's slide 16.
Or Oscar, I don't mind fielding this to start, and if you don't mind following up with anything I might miss. Yes, this was a piece of work that was conducted by some of our epidemiologists with Oscar. And basically what we did is we looked at the seasonal variation for 5 years prior to COVID, the national prescribing trends in the community. And then we compared that against the by percent change in the blue sections here starting in March. So as you'll recall, the public health interventions timed with the land border closing between the United States and Canada happened about mid-March. And so we didn't see such an impressive change starting there, but then an immediate 40 to 50% drop here in the preceding 2 months. And we were a little unsure at the time when we did this calculation as to the exact reason, whether it was a decrease in communicable diseases or whether or not barriers to access to care were playing a factor. But we were happy to put this out into the realm and see what people had to say. I'd like to point people to some of the collaborations that we've had with Public Health Ontario, who using access to some of the OHIP data, were able to dive a little bit deeper. And as Dawn was saying earlier, a lot of the times, the patients that actually received care for specific conditions, the proportion of interactions that resulted in an antimicrobial recommendation remained largely unchanged. So an overall total decrease, but if you look at a by diagnosis analysis, you'll see that the proportion that received antibiotics remained relatively the same. So I hope that answers the question. Oscar, do you have anything to add?
Thank you, Jason. Just to add that these results reflected the community sector, but these findings are not far from what we see at an international level, because findings are similar to results published online with our international partners. However, we are closely following recent evidence that in-hospital antimicrobial use has increased dramatically. And rates of AMR in COVID-19 positive patients who might be hospitalized has also increased during this period. So there is a work going on to depict the evidence and to see if this community-rated change is parallel with or contradicting the hospital-rated data sources. Thank you.
Well, thank you both. We have a few questions that fall under the heading of representativeness. So can you comment about, please, the representativeness of the data from IQVIA, and also whether the data that you have or your plans for expansion of the data will include certain populations? You've mentioned northern and rural, but we need to, some explanation of that would be great. Also corrections, military. So I'd like to hear a little bit more of plans for or current representation.
Sure. Why don't I start by talking to give Don a few seconds to prepare, because I'm reminded when he first joined the team, we were very happy to have him, but it was one of his first questions that he came to us about our national estimates of antimicrobial consumption in the community. And so, Don, I wouldn't mind if you fielded that question, because you wrestled with it yourself, and maybe share a little bit about where you landed on that, where you think we can secure better sources of data, and how it fits as an overall national program.
Yeah, I think this is a really challenging question. And one of the exercises I think that needs to be completed is really the mapping exercise. Trying to get a vision of what the Canadian healthcare system looks like using data from CIHI or other, and actually mapping our surveillance systems in a quantitative way to them. And I say mapping because I don't mean that we have to create a CNISP system, for example, that has the exact number of each of the hospitals that there are in the country times a factor of 0.2, but rather that we recognize that we have conversion factors that we can use to adjust our data so that if the CNISP network, for example, is underrepresented in one area but overrepresented in a second area, that we can correct that data to generate sort of population estimates. And this isn't me just being creative here. This is exactly the methodology that's being used in the European reports to generate their national estimates from their sentinel systems, many of which have actually significantly reduced coverage compared to what we do. It's always the challenge with a sentinel system, because you can expand them infinitely until they are no longer sentinel systems and they are comprehensive, collecting every piece of data in the country, and that becomes impractical, and there's a point where it is no longer efficient to do it. It's better, I think, to focus on expanding the representative nature of it and making sure that we have all of the sectors like long-term care, inner cities, rural populations, northern populations well covered. Now, the backstop to this, of course, is that we also have AMRNet. So AMRNet has the potential to give us truly comprehensive national AMR data. We have the potential to actually have essentially every single culture that is in the country, because of course they're all handled through microbiology labs. Now, I'm sure it will never be a complete 100% because nothing is that simple in this world, but it's a very good way to get at these national level estimates that then marry with programs like CNISP that can give us the much more rich data that we get from a sentinel system that allow us to ask and answer questions about the large scale trends we will see when we download numbers that say MRSA has gone up by X% in Y region. What do we think that's all about? We then have our sentinel system that backstops us and allows us to dig in and actually see if we can figure out the drivers and then the potential actions that can roll out from that data.
So to add on the IQVIA front and the representation of that system, on the back end, we have the opportunity to, I'll say, put some of those clever adjustments on the IQVIA data and see if we can parrot that data to be more close to what the publicly funded drug plans are. So in many jurisdictions across Canada, seniors are covered by governmental drug plan. And so that gives us really good data on how many drugs, how many antibiotics are being prescribed in the community sector. And so with some of these adjustments, I could say there's a high degree of correlation between what we see in IQVIA versus what we see is covered by the provincial drug plans. But then we have that dark spot, the black box, where there's private insurance, and then there's privately funded types of access where people are paying sometimes out of pocket for antibiotics. And so we have very little line of sight on that. But with what we do know, where we can do our best to compare apples with apples, we do see a high degree of correlation between publicly funded access to antibiotics and what we see in IQVIA.
Thank you. That's comprehensive replies. Thank you. We have time for just a couple more questions. One would be, what is FACT's plan, if at all, to support provinces and regions in taking action on the data and the trends that we're seeing in the CARS report?
So I think there's a lot to unpack in that question. If I could paraphrase it, is how does the federal government plan to fix AMR in Canada? As you can imagine, that's
I would actually reword it as, you know, where can we, what are the mechanisms for addressing these trends?
Yeah, I was just being a bit facetious there. The actual answer, I think, lies in what we're spending an enormous amount of our time working on right now, and that is the Pan-Canadian Action Plan. So that work that we are doing internally and with the provinces and territories, and reactivating the efforts that were going on right up to COVID, and of course got a little bit derailed by this little thing called a pandemic. Reactivating that, working on that, which we're doing right now to assess, okay, now that we're post-pandemic and that the landscape has shifted, now that we have these updated data, how do we prioritize the actions that we had laid out in 2019 and early 2020, now in 2022? How can we work with the provinces to tackle those priorities? Where does work lie on the provincial side, the federal side, and where is there a shared responsibility? So I think the answer really is the Pan-Canadian Action Plan is the key tool to figuring out the best way for action in response to this data.
I'll go so far as to say the agency alone will never solve AMR surveillance here in Canada. And we truly need input from all of our public health partners across the country. With specific ties here to the CARS report that was part of the original question, I am happy to say that we've had some great conversations with some of our PT partners. Let me pull one out of the hat. We've recently identified Newfoundland and Labrador as habitually high rates of prescribing in their population. And we're very pleased to say that they've really taken on the charge. And we've seen their per capita prescribing decrease above and beyond anything we've seen in any other jurisdiction. And so we'd like to showcase that a little bit more in the CARS report to show some of these good news stories. But you will find us ready, willing, and able collaborators on any front. If you see an opportunity in your jurisdiction and you'd like to reach out and have a conversation, please don't hesitate.
Thank you. And it's great to be reminded that that action plan was very much in the works and now is being, dare I say, resurrected, but certainly could lay out the ways forward for many of us. You gave us a choice, Dawn, of which we preferred, but of course, they're really all important new areas and initiatives. I want to thank you all again for your time and your presentations. Very, very informative and really quite exciting. I'd like to thank the National Collaborating Center for Methods and Tools for joining us today and potentially joining us on further knowledge translation of this important information and these opportunities to network and move forward. And to all of our attendees, thank you for joining us today. When the webinar closes off, you will be immediately given a survey to quickly fill in, we hope. It provides you a chance to evaluate today's session and make some comments on what other information you'd like to hear from all of us today. So I bid you a good day and thank you very much again.